Practical number 2, the assessment of the upper neck involvement in the temporomandibular disorder. In this practical session, we will assess the involvement of the upper neck structure in the clinical presentation of the masticatory system. So the outcome measure, which will be the best one for us, is the pain-free mouth opening. So we will assess the pain-free mouth opening of Sophie, and then we will apply some cervical spine maneuvers. One of them will be full side flexion, the other one will be full rotation, and then we will add compression and destruction, and we will see how these maneuvers are changing the pain-free mouth opening. Finally, we will also change the general posture of Sophie, and we will see how her pain-free mouth opening is changing, or whether it is changing or not. So first we need to see how we are measuring the mouth opening, and it's very simple. We go with the metal ruler from the midline between the two upper teeth and the midline between the two lower teeth, and we take the millimeter measurement. So open the mouth. It's very intuitive. Okay, from the bottom point between the two upper teeth to the top point between the two lower teeth, exactly 45 millimeters of pain-free mouth opening. Now we will add side flexion that is more biased to the upper neck, because we want to challenge and stress the upper neck of Sophie. And we will take the measurement, and it goes down to 35 millimeters. Then we do the right side, and it goes down to 38 millimeters. And I will repeat it again to see that it is reproducible. Now it's 40, and now it's 39. So we could see that with this movement, the range of motion of Sophie reduced from 45 to somewhere below the 40. That means there is some potential connection, a functional connection between the maneuvers of the neck, of the upper neck, and our most important outcome measure. Now we will test the response of mouth opening to full rotation. So I will ask Sophie to rotate her head all the way to the right and open. It's 45, and then to the left it's 46, and again it's 45, and again it's 45. So we can see that the rotation did not make a difference. The side flexion did, equally to both sides, and the rotation did not. Now let's move to the compression and destruction maneuver. So I will compress Sophie's head with something like 10 kilos estimation. Don't overdo it. And she's all right, she's 45. I'll do it again. 45. So compression did not make a difference. So after we assess the compression and its effect on the pain-free mouth opening, we will assess the opposite, the destruction. For the destruction, I will put my biceps behind the occiput and my hand on the forehead of Sophie and lift something like 10 kilos, 5 to 10 kilos, and then take the measurement of the mouth opening, which is 45, and again something like 45 or 46, which was exactly her range of motion in the neutral position. It means there is no difference. So compression, destruction did not make a difference. Side flexion did to both sides, reduced the range of motion quite dramatically, and the rotation did not. So it's only one component up to now that made a different with Sophie. Now we will assess the general posture effect. So I will ask Sophie to slouch a little bit and see and open. And she reduced to 40. And again slouch and open. And she's around 40, so it made some difference between the 45 and 40. Now over erect yourself and open. And it's 46. And again, erect. And it's 45. So slouching made a difference and the erection did not make a difference. So there is something with slouching position that reduces the pain-free mouth opening of Sophie. And it tells us that something out of the jaw is affecting the pain-free mouth opening inside the masticatory system. So we started from 3 functional assessments. So we assessed how a different position of the neck is affecting the mouth opening, which is quite functional because during the day we may be in a slouch position, in a erected position, we may be with a side flexed position or with a rotated position while we are chewing or while we are speaking. So that's more a functional assessment. The next thing we're going to assess is a more formal upper neck test, clinical test of the upper neck. One will be the deep neck flexors performance, and the other will be the flexion rotation test. So the 2 formal quick tests for the neck that we're going to do is first the craniocervical flexion endurance test, and then we will do the flexion rotation test. One is for the endurance, muscular performance, and the second one is from upper neck mobility. So we assess the performance of the muscles and the mobility of the joints, and then we have a nice quick test or quick test picture that gives us picture of Sophie's upper neck condition, and then we will calculate all together with the functional assessment that we did just before, and we will decide whether we are going to assess thoroughly the upper neck of Sophie or whether it's not required and we can move on and assess only the masticatory system. So craniocervical flexion endurance test. In this test I will position my patient like this with on the back with the straight legs, and I will bring her head into a neutral position that the forehead and the chin are in the same plane. With Sophie it works well. With some other patients you may need to put a towel or a pillow in order to adjust the height. But here it's perfect at the moment. Then I will ask Sophie to tuck the chin in like this, as if you are holding an apricot here under your chin, and don't clench your teeth please. And then lift your head just a little bit, that give me enough space to put my hand. And then I'm observing Sophie, and you can see she's starting to shake, and then she cannot continue to do it. So where will we stop? We're going to clock Sophie. I just taught her now how to do it, yeah? But we're going to clock her. So when will we stop the clock? When she's taking the chin out, and we give her only one warning, and the second warning will be game over. So it's a yellow card and a red card in a way. Okay, and then we stop the clock. What is a good result? In an overall population, if you cross the 20 seconds, it's quite good. If you are below the 10 seconds, it's quite bad. If you are more than 30, you are getting more into the athletic population performance. So that's our thumb rule. So 20 is somewhere starting to get close to the average. So let's time Sophie. So tuck the chin in, lift your head up, and now I'm observing. Okay, that's one correction was, and that will be the second correction, and she's somewhere around the 10 seconds, 10 maybe 12 or 11 seconds that I clocked using my clock in the clinic. So it is quite positive. So her upper neck flexors are challenged during that test. The second test is the flexion rotation test. In this test I'm going to assess the rotatory mobility of the upper neck versus the lower neck. Because I am going to flex Sophie's head, her lower segments are going to get blocked and there will not be available movement, but C1 and 2 will still stay with available movement because of the facetar orientation. So this test is a nice test to differentiate between mobility of the general neck and specifically the upper neck. We are biasing the movement to the upper neck. So let's perform the test. And just before we perform it, just reminding you that this test is considered positive if the range of motion is less than 30 degrees. So if she's crossing the 30, then she's okay, she's negative, and if she's not crossing the 30, she is positive. Crossing the stopping point would be either pain symptoms or resistance number 2, or the maximal resistance. How can we assess if it's 30 or not? If we are looking at the nose like a compass, if it would go all the way to the shoulder, it would be 90 degrees. Now, if we are dividing it into 3/3 and she's not in our mind, and she's not crossing the first third, that means she is positive because she is less than 30. So just imagining what is 90, no one will get to 90, but you just imagine it in your head, and then you apply the test and you see if she's crossing the imaginary 1/3. That was validated in a study of Toby Hall, that the same instruction like now will lead you to get accurate results. So to perform the test, I will need my patient close to me a little bit more, and lifting the head and flexing the neck all the way. Tell me if you have any symptoms, Sophie, okay? You right? Mm-hmm. Okay, full flexion. That's a full flexion. Preferably if her head gets into the horizontal position, as if she's sitting or standing. Now, I'm reinforcing the upper neck flexion. I'm observing her nose as a compass, and then I'm starting to rotate. To the right, she's crossing the 30 easily. To the left, she's starting to get something. Tell me when exactly?
There.
Okay. Just on the area of the 30, she's getting some symptoms. So I would consider it as a positive test on the edge, but still positive to the left. So flexion rotation test positive to the left. Craniocervical flexion endurance test positive. And side flexion, pain-free mouth opening of side flexion is also positive because it was reduced. So out of 5 tests that I presented you, 3 functional and 2 formal tests, 3 are positive. That means that the majority of the tests that we performed are suggesting that there is a connection between the upper neck and the temporomandibular disorder of Sophie, and that means I need to assess thoroughly her upper neck. If it would be only 2 out of 5, then you are on the edge. If it would be 1 out of 5, I would say it is not enough. If it would be 5 out of 5 or 4, of course you need to assess the neck. So just a thumb rule to decide whether we are going to spend time in assessing the upper neck or whether we are able to skip the neck, leave it behind and move to assess the jaw. That's the bottom line of this practical session. 5 tests, quick tests for the neck, 3 functional, 2 formal, calculating everything together. If we have 2 or 3 or more that are positive, then we are going to assess the neck. If we have 1 or less, then I would suggest not to assess the neck and to keep it maybe later on, only if the patient is not responding to what you're doing.